Thanks everybody for those incredible talks. We have just a few minutes for questions, and if anyone in the audience has any, please come up to a mic. Dr. Tonki.
Is there any role for arthroscopic assisted tibial plateau fractures?
Uko, you want to take that? Or?
Yeah. I think there are some indications, select indications. Again, I think it's a little bit training bias. There's a lot of things we see. If you are doing arthroscopies on your regular practice, you have a more tendency to do arthroscopic assisted tibial plateau fracture reduction and fixations. But most trauma surgeons don't want to even hear the word of arthroscopy. So it's a little hard to kind of convince trauma surgeons to do it. I think for a typical lateral tibial plateau depression fracture, probably you don't need it. The ideal situation for an arthroscopic one will be like rare type 3s, right? Pure depression that you don't have to do incision. You can actually arthroscopy and fluoroscopy assisted elevation and backfilling, and that should be it. So this is the ideal situation. The other ones that I use for arthroscopy are the ones that we don't have great exposure, right? The medial plateau. Most medial plateaus are splits, and we are able to fix them fluoroscopy assisted, but sometimes there are some patients who are going to have depression of the medial plateau or anterior part of the medial plateau that you may want to make it as perfect as possible in younger patients. These are usually my indications to do an arthroscopy and fluoroscopy assisted reduction and fixation.
So I know in my neck of the woods, Mark Swinkowski is actually very interested in this, and this has been the main part of his clinical practice while he's been JBJS editor, and he actually has a federally funded big study to look at that, arthroscopic assisted and type 2 fractures, I think primarily. Chip?
Hi, I'm going to take advantage of my advanced age here and say for a posterior dislocation of the proximal tibia, mostly soft tissue wound injury, I used to use a Steinman pin from the patella into the proximal tibia, provided it wasn't broken. A technique devised by Dr. Katzbaum in 1965 is when he wrote about it. Still very handy in the ED. And the other is, anybody use hyperbaric oxygen anymore for reperfusion injuries to the calf or leg muscles?
Who has access to a hyperbaric chamber? We have an awesome one in Minneapolis, but Eric is maybe the same one we have. Yeah.
I think hyperbaric oxygen use is a little conflicted with the institution and the investments. I don't think scientifically has been shown. It may be a select part of the patients that has actually oxygenation issues medically for other reasons that may be helpful. Otherwise, most trauma situations, I don't think is really much use of it.
Yeah, I would agree. We use them a lot in the past, but not now. So
we use our hyperbaric lab a lot for transcutaneous oxygen.
Yeah, wound. I mean, just there's some argument for some chronic wounds where it is, but not not typically. If they become trauma, I mean, if they're traumatic wounds, and our job is to get those covered, then we don't use them for. Use it. We have access to a lab, but it's really in our diabetics and our places that are poor candidates for flap coverage.
Go ahead.
Yeah, in a case specifically dealing with the posterior or lateral tibial plateau fracture, where the cortex might be an osteopenic female, the posterior cortex is comminuted, and you don't really think you can pop up that lateral plateau without blowing out the back. So you're looking at a lateral approach or a posterior approach in a prone position. I'm wondering, do you use the fixer, a distractor, to try and take a look back there? I mean, it's hard with the knee. You can't have the knee in extension. You've got to have the knee in flexion. And just wondering how you're fixing that, Dave, or in the panel.
Yeah, I mean, I think there are a couple different variations on those posterior column injuries where you have the whole posterior column for the, in which case you can do more of the There's a couple options. So you can do sort of like the Lobenhofer approach. It's actually the same interval that I was showing, and that approach is just done more in a prone position, and you make the skin incision a bit more posterior over the medial gastroc, and that lets you get back there. And then you can sort of frog the leg out and still do an anterolateral approach if you need to. I think it's challenging to use the distractor in those cases with that type of positioning, though. So yeah, you're going to have to do more just sort of manual manipulation to maintain the alignment in the way that you want. The other option for posterior lateral is like the Froche sort of. It's a very limited posterior lateral that goes behind the fibula. That can be done, with the same, and you modify the skin incision a little bit, but allows you to get to that posterior lateral part of the tibia, but it's through a relatively narrow window because of the branching of the anterior tibial artery, and so it's a fairly. That's why I said 95% of the ones can be treated with the two that I showed, because it's a very small number, I think, that actually really you actually need to go back there. But if you need a really short little buttress on that posterior lateral aspect, that is one way to do it. With that, because you're supine, I think you can actually still use the distractor and do things the way, kind of more like what I described. It's just that you'd also have this other window that's going behind the fibula.
We use the posterolateral approach with the fibula osteotomy, and this has several advantages because you can really get the lateral collateral ligament out of the way and open widely the post-lateral and posterolateral compartment in order to address these fractures. Otherwise, actually, 50% of your lateral compartment are hidden because it is behind the LCL. And this approach is chevron osteotomy of the proximal tibia, isolates or intersects the peroneal nerve, and then you have fantastic overview over the entire lateral compartment. So we prefer this very, very much, and we use it quite a lot.
I think I'm going to be a little controversial. So I agree with the exposure part of it, but I think we're going to assess the risks and benefits. A couple comments. One, most of the elderly posterolateral comminuted fractures of the posterolateral depressions probably don't need to do much. I don't think that the benefit of doing anything versus the risks is worthwhile. So you can leave them alone, and I don't see that they are becoming a problem. Again, elderly osteoporotic comminuted fractures. The one you need to get there, you need to reduce it, and you should be able to apply some fixation, right? You need to have a good amount of bone, usually in a shear fragment, and these ones are not that common that you may need to do a posterolateral approach. Most posterolateral approaches, you can go around the LCL on both sides, like Froche or osteotomy of the fibular head, or you can even go the LCL detached from the femoral side. It will give you good exposures, but the indication to get there is not that many. The other thing, the complications after these exposures are not small. A lot of them gets more stiff than you think, and some of them will end up persistent peroneal nerve sensory findings. So persistent, not temporary, peroneal nerve sensory persistent problems. So I think you got to be careful. If you do a couple of them and you see the problems, then you got to be more reluctant to do another one.
Well, with that, we need to conclude the session so we can have some break and get up to our lab sessions. I know Dr. McLeod wants to make a brief announcement before we break. So thanks to the panel for their wonderful talks, and Ted.